Hello, and welcome to this webinar on assessing capacity. I'm Leo Briggs. I'm Deputy Head of the DDU. I've been a dentist a long time now, so I think I fall into the category of been there, done it, got it wrong, and hopefully learnt from some of the mistakes, which possibly puts me in a good place to do the role that I now do. And I'd now like to introduce my colleague, Rachel.
Hi, I'm Rachel. I'm one of the dental care professional advisors at the DDU. My background is clinical as a dental therapist. I qualified in Leeds in 2008 and I've spent time working in the hospital and community dental services, but also in NHS and private practice. Currently, I split my working week between the DDU and as a clinical tutor supervising undergraduate students on clinic. Okay, so just before we get started this evening, we have a poll for you to vote in. It's just to give us an idea of who we've got on the call this evening. So if you could please vote now. Okay, so yeah, so pretty much what we thought, Leo. So the majority dentists, but we do have some dental hygienists, dental therapists, orthodontic therapists, I think, and dental nurses. So that's great. So welcome everyone, and we hope you find the webinar useful.
Yeah. So what I wanted to start with was two of the basic principles of medical ethics, because this really does tie in with assessing someone's capacity to be able to consent. The first one is autonomy. Patients have the right to choose what happens to them or doesn't happen to them. So that's an absolute fundamental principle. The second one is, I'm going to try and get the word right, beneficence, which is doing what's best for your patient. So it is that you must act in patients' best interests. Now, sometimes those two might seem to conflict with each other because patients might want something that you don't think is appropriate to do. And when that is the case, you need to not do it. You need to explain sensitively to the patient why you don't think it's appropriate for you to do it, why you don't think it's in their best interests. Just because they want it doesn't mean they must have it. But we appreciate that those can sometimes be conflicting in your mind, especially, and also with patients. They often say, I've got the right to this. That's not necessarily the case. And before I go any further, if you do have any questions, just put them into the Q&A box and we will deal with as many as we can at the end. So, consent, what is it? It's the expressed or implied permission of a patient to undergo a dental examination, investigation, or treatment. So basically, the patient needs to let you know that they agree to something. That's all that consent is at its heart. Rachel.
Yep, so it's important to remember that consent is not a one-off procedure. So it's a continuous process that can be withdrawn at any time. So just because you've got a signature on a form, it does not replace a conversation about treatment. Therefore, remember to have those discussions with your patients about risks, benefits, treatment alternatives, and where applicable, costs too.
Yeah, and remember that it's ongoing all the time. Always think, do I still have consent is the way to view it, not I have got consent. Consent can be implied. That means that you assume you've got consent. You can only rely on that for an examination of a patient. So if the patient turns up, gets in the chair, opens their mouth, you can use implied consent for that. But for anything else that you do, you must have expressed consent. So the patient must let you know that they're willing for you to proceed. The vast majority of the time, it's oral consent. And when we say recorded, we mean recorded in the records by you, not a taping of it. It should be recorded in the records always. Sometimes it's not. You don't have to have written consent. So it's more important that you have the discussion with the patient. Because that consent form, it's only one piece of information to help show that you tried to get consent. It doesn't actually prove you got consent. So it is mandatory when you do treatment under sedation or GA, but otherwise you don't have to have one. Some organisations that people work for do insist on it, and then obviously you need to comply with your workplace requirements. But actually, from our perspective, the really important thing is that you have that discussion with the patient. If you do that, you're much more likely to have consent from the patient. And it's fundamental. If you don't have consent, there might be an action for damages. We do see that in claims quite often. Claimant solicitors will say that you didn't obtain consent, and they add it to the claim. And also regulators, we do see it as an allegation at the GDC that you did not obtain consent. So it is really important that you do it. And also, if patients have been warned, they're much less likely to complain or to bring a claim against you. It's that age-old thing of warning about things that are likely or could well happen. If they do happen, the patient isn't panicking when it happens. And if they don't happen, they think you are a fantastic clinician because it hasn't hurt, it hasn't done all the things that you warned might happen. It's always a balancing line with the individual patient, because what you don't want to do is scare patients, but you do need to warn them. So it's being that cautious practitioner is the way to proceed.
So there are 3 principles of consent. So the patient needs to have capacity or competency to consent, and we'll talk about this in a little bit more detail later in the presentation. And in order to make a decision, the patient needs to have sufficient information about the treatment. And finally, the patient needs to come to a decision about treatment voluntarily, so not coerced towards a certain treatment by anyone else. And that could be a clinician, a family member, or even a care worker. So just to bear that in mind.
Yeah, and remember, if a person who has the capacity to consent is competent to consent, refuses it, then you must not do the treatment. So if you have a situation where you say to patients, lift your hand and I'll stop, as soon as they lift their hand, you must stop, because that is in effect them withdrawing consent. So even as I said before, you know, when a patient wants you to do something that you don't think is appropriate, don't be coerced into doing it. Don't be cajoled into doing it, because when things, or if things do go wrong, patients will turn around and say, I didn't consent to it, and it was an inappropriate thing for you to do. How can I have consented, agreed to have something done that should never have been done? So just always remember that. A little bit about some of the law which affects us. This Montgomery judgment, as it's referred to, back in 2015, landmark decision in the UK, because it made that change from what previously we were judged by what a dental professional thinks a patient should have been told. And this confirmed that actually it has changed to what a reasonable patient in the same condition as that patient should have been told. So when you're thinking about consent, thinking about the information that you give to patients, you need to put yourself in the patient's shoes. Really hard when you're a clinician, because you are always thinking as a clinician, but you actually need to put yourself in the patient's shoes to decide, what does somebody in this in the same position as this patient need to know? want to know. And then you do need to provide them with the material risks. So that's always important. A second landmark judgment is the one called McCulloch. And again, this is really helpful to us as professionals because this confirmed that we are the ones who decide what are the reasonable treatment options for a patient. So we don't need to tell patients about every single treatment option. If you think something is unreasonable for that patient, you don't need to tell them about it as a treatment option. For example, if a patient comes in as an emergency patient in pain, you don't have to say, I can do no treatment. No, it's ridiculous if you think about it that way. It's why have they turned up in pain, and you turn around and say, oh, I can do nothing for you if you like. So you don't have to do that if you think it's unreasonable. So you decide which are the reasonable options for the patient, and then you then need to flip it to putting yourself in the patient's shoes, and what does the patient want to know about that particular option. I've just seen a question that came in, which actually I think is we're going to do most of the questions at the end, but this one I think is a really important one, which says, are you sure we don't need a written consent? What if the patient forgets the discussion? That's a really good point, but actually, patients, you need to reiterate things. Patients do often forget things, so that's where, when they next come in, reiterating it, going over it again, checking that they've understood. But also, patients who have memory loss might forget that they've done it, but it doesn't mean they didn't consent at the time, and we'll be coming on to that later. So it doesn't prove that you had consent. It proves that the patient signed the form, unfortunately. Some practical tips.
So just some practical tips now. So discuss treatment with your patients rather than present treatment to your patients. So historically, it was more common to see that a dentist or a dental hygienist or a dental therapist would just tell the patient what was required and get on with it with minimal discussion. Whereas nowadays in modern dentistry, the emphasis is more about the patient making their own decisions about their treatment after weighing up all of the options, following an informed discussion with a clinician.
Discuss the reasonable alternatives. And I've already covered that, so it's that if it's appropriate, discuss the option of no treatment. But with every option that you discuss with the patient, you need to explain the consequences of choosing it and the consequences of failure. I know we don't like talking about failure, but it's that what happens if it doesn't work. That's really important. My background as a periodontist, all the time I'd be saying, if we can't get the disease under control, you're likely to lose your teeth. So it's that consequences of failure are always really important. It might seem like an easy option to choose the option of having no treatment, especially for a nervous patient, but they need to know what's likely to happen if they choose that. So that's always really important to do. And then keep good records. When we say full notes, don't mean that they have to be pages and pages long. They can be succinct, but make a note of what you discussed with the patients. It is more than a consent form. And always be careful with auto notes. It's very easy, especially when you're pushed for time, to have put an auto note in and not edited it. And it can come back to haunt you. We have seen so many where patients were informed about the risk of oroantral communication when taking out a lower tooth. Oops, warned about the risk of their tongue being numb when you're numbing up an upper tooth. All of those sorts of things are from auto notes. And if you've got something that's a blatantly, obviously wrong, all of your record keeping is called into question when there's something like that. So be careful with the auto notes. Make sure there's enough time. Easier said than done. We fully appreciate that. And I'm sure Rachel has weekly examples where that's easier said than done.
Yeah.
But just try and square that circle. You know, it's putting in the time to help prevent problems and to make the treatment go as smoothly as possible, because that time invested at the beginning and then during having those good, effective communication with your patients helps smooth the whole procedure.
Okay, so it's about focusing on the individual patient. So do you need to adapt your communication skills and/or method? We can use the internet to explain treatment now, or draw diagrams, or utilize 3D models and scanners. Can we provide the information in a more accessible format or different language? Do we need to involve the patient's family and carers in the conversation? Does the patient's medical condition mean that they have fluctuating capacity on different days at different times? Ultimately, is it clear from your notes that you have taken steps to understand the concerns and circumstances of the individual patient? And have you engaged in a genuine two-way dialogue where questions have been asked and answers have been given, and has that been documented down?
So don't simply focus on percentages. It's not just the size of the risk that's important. It's whether it is important to that patient. For example, with implants, you know, if you have a 98% success rate, what happens for that patient who's in the 2% who it fails for them it's a 100% failure. So, you know, the percentages aren't the only thing to discuss. It's important to put it into perspective. You know, this is likely to happen for you. This is unlikely to happen, but it could. So that's the sort of discussion to have with the patient, not just the it's going to be successful in 98% of the cases. And then, has the patient understood? Is it clear that they've understood? And that's always difficult, but just do your best, basically. Try, reiterate, and check that they've understood, and wherever possible, give a cooling off period, so that patients have that chance to think and come back and ask questions. Obviously, you can't do that with urgent care. You can't do that when someone's in pain. Sometimes you have to proceed swiftly, but wherever possible, allow a cooling off period before treatment starts. Now, patients who may lack capacity to consent. As Rachel's already mentioned, capacity can vary over time. Someone might not be able to consent at one point and consent later. Somebody might be able to consent at one point, not consent later. And also the complexity of the procedure. It's relatively straightforward to give consent for an examination. It's relatively straightforward to give a consent for polishing of your teeth. It's far more difficult to understand full mouth rehabilitation. So it's think about the complexity of it. And then if in doubt about the patient's capacity to consent, think about getting a second opinion. Second opinions are really helpful because it helps you decide, collaborate with others as to what you think is best. And then also, if you are concerned that somebody's consent, they might not be able to consent, ask them to involve others who are involved in their care. Then a patient might have capacity to consent, but they are getting a bit confused about things. Try to involve others, ask them if you can involve others, and that can be really helpful.
Okay, so we've just got a scenario now. So you see a 33. She has type 1 diabetes, which has been reported as well controlled. When you see the patient for an examination, her behaviour is erratic. She is reluctant to sit in the dental chair, and she repeatedly says that her mouth is too dry for you to examine her. You eventually get her to sit in the dental chair and accept a clinical examination, and you are suspicious that there is an infection from her upper right one. You want to take a radiograph of the tooth. The patient refuses. How should you proceed? So I think initially we need to think about the patient's welfare and does she require medical support? So because of the erratic behaviour and the dry mouth and the diabetes diagnosis, does she require medical assistance at that time? Moving on to the clinical part of the scenario, as there is a potential infection related to the upper right one, any treatment would fall out of scope of practice for a dental hygienist or dental therapist. So this is when team working needs to come into play. And at this point, I would seek advice from one of the dentists on clinic. So I'm going to bring Leo in to support the scenario now, just to give us a little bit of advice on how to manage something like this.
What you have to do is, in this situation, try and explain in a different way the importance of taking the radiograph and explain to the patient why you can't proceed safely without it, because you need to know what's happening. Ultimately, if the patient chooses not to have it, make a careful documentation of the discussion that you had. Also, make a note of her change in behaviour to how it normally is, and also make a note of what you advise the patient regarding their general health. And in the discussion, do it sensitively. It's not I think you need a bit of sugar, love. You're going a bit hypo. That's not the way to deal with a situation like this. The situation is to have that careful discussion with the patient, report it carefully, but ultimately, you haven't proved that this patient lacks capacity to consent, so you have to assume she can. And that's what I would try and do, all on the spot when I've been called into the room by someone else. Thanks, Rachel.
Thank you very much.
Yeah. Now, the Mental Capacity Act, 2005. The starting point with this is that anyone who is age 16 and above, you assume they have the capacity, the ability to consent, until you establish that they don't. So that's a really fundamental thing. You must just assume that people have that capacity until you can prove they don't. Really, really important. So
I think we're just moving on to another poll now. So this is a multiple choice question. So how many principles are set out in the Mental Capacity Act 2005? So I'll just give you a few seconds for you to all vote on this, please. So that's good. That's really good to see, actually. Yep. So the answer is 5. And we're just going to go on to talk about that in a little bit more detail now.
Yeah. So first principle, must assume that a patient has capacity unless it's established they lack it. I've already dealt with that. It's so important. You can't treat someone or assume that someone cannot make a decision unless you have taken all steps to help them make the decision, and that's been unsuccessful. which is onerous. You've got to do as much as you possibly can to help them make a decision. The third one is that a person is not to be treated as unable to make a decision merely because they make an unwise one. Basically, patients can make silly decisions if they want to. It doesn't mean that they lack capacity. We as clinicians can't do that. We can't make silly decisions. We have to act professionally, but patients can make an unwise choice. It is ultimately their one. If you do something on behalf of someone who lacks capacity, once it's been established they do, you must be doing what is in their best interests. And we'll come on to that later as well. And then before you do anything, you must do it in the least restrictive way possible. That doesn't often apply in dentistry because it's hard to restrain people in dentistry, but if there is any form of restraint, it's got to be the least restrictive possible. That's far more important when it comes to medical care and also when it comes to living welfare arrangements for patients. So deciding if someone does lack the capacity to consent, there are two steps to it. The first one is there an impairment of their mind or brain, or a disturbance in the way that their brain is working? And then that might be permanent, it might be temporary. So firstly, is there something that's causing that? The second thing is, does it mean that they can't then make the decision at the time it needs to be made? So those are the two steps to it. And then a person's unable to make the decision if they can't understand the information relevant, they can't retain it, so they can't keep it in their mind long enough to be able to weigh it up and then communicate their decision. So those are the four steps. This can be difficult with patients with dementia because they may well have the capacity to make the decision at the time. They can weigh it up. They can hold on to the information for long enough to weigh it up and communicate it. The difficulty is that a bit later they might have forgotten that they did that, and that can lead to all sorts of practical problems about patients coming back saying, I didn't know this was going to be done. They did. They were able to make the decision at the time. And again, that's where having really good records can help. So if those criteria are not met, the patient isn't able to make the decision. But as I've said, if they can retain it only for a short period of time, it doesn't prevent them from making it. And you cannot assume someone lacks capacity just because of how they look, how they appear. So you mustn't make assumptions. You mustn't be prejudiced by what you see, what you hear from a patient. You've got to really analyze things carefully before deciding that they do lack capacity. When it comes to helping a patient to make a decision, there's a supporting document that sits alongside the Mental Capacity Act, and it goes into quite a lot of detail about the sorts of steps that you can take to try and help. So it's using different forms of communication, providing information in a more accessible way, making sure that you chunk it down into usable bites of information, using different forms, more accessible. So maybe it's something as simple as using larger print for someone who's got some eyesight problems. There's all sorts of ways that you can make it more accessible. Keeping your language simple is really important. If there's a medical condition that might be affecting their capacity, get it treated. that example earlier about the diabetes, that might well a bit come into that category. And then having a structured program to improve capacity to make particular decisions, again, that's really difficult as dental professionals. I don't think we've really been trained how to do that. And this is where you would want to work collaboratively with other health and welfare professionals so that you are trying to help that patient, and the dental care is tied into that integrated well-being for the patient.
Okay, so we have another scenario now. So you are midway through a course of treatment for a 72-year-old married patient. He attends on his own. His appointments are usually in the morning, but today his appointment is late afternoon. For 6 weeks. When he attends today for a filling in his lower right first premolar, he explains that he had a fall a couple of days ago. He appears agitated. He tells you that he thinks he might have banged his teeth in the fall, but he is vague about what happened. What should you do? So there are lots of areas to look at here. Is there anything going on medical history-wise which would cause his agitation? Does he have concussion from the recent fall? As we know, it takes longer to recover as we get older. Has he been to the doctor? Is he having any problems with his teeth since the fall? What can you see? Is there anything that requires urgent attention? So it's all about gathering information. If it's obvious he's not able to answer the questions appropriately, you could consider calling the patient's partner, with the patient's consent, of course, to try and gain some more information. If nothing urgent is required, and you feel the patient doesn't have capacity to agree to any treatment today, you could consider booking the patient back on a morning appointment. It's all about gathering as much information as possible and making a decision whether to treat or not to treat on that day. Ensure your reasons for the decision are fully documented and explained to the patient, and that you are always putting your patient's interest first. So it's a tricky one, really. But Leo, is there anything that you would like to add to that?
Yeah, I mean, with a patient like this, you are starting to just wonder if there might be dementia creeping in. And that's always difficult because some patients with dementia are more agitated in the afternoons, late afternoons, than they are in the mornings. It's quite a classic thing to see. But also he's fallen, he's had a bang. Was that because he's getting more unsteady generally, or is it because just one of those things that happened and the banger's given him a bit of a bit confused, following that. There's a lot going on in this one, and it's trying to tease it out and work out what's the best thing to do. And I think what Rachel said, look at the dental things. Is there anything urgent? Deal with that. If there's nothing urgent, deal with the agitation, and then try and work your way through it. Really, it's a tricky one. What is the best interests of a patient? It's difficult to decide. There's no actual definition of it, but if you take common law before, it's actually there should only be one course of action, which is definitely the best. And it's not just about the medical, the dental. It's about welfare, social, emotional, psychological, and other interests, which, again, as dental professionals, we might not know. We might have a lot of that information if we've been treating the patient for a long time. And so having established relationships with patients can be enormously helpful. But if you're seeing someone for the first time, you're not going to know those things. And so that's where you need to consult to try and work out what is in the best interests of the individual patient.
Okay, so we've just got another question for you now. So it's the final poll question. So it's a true or false question. An enduring power of attorney can be valid for health and welfare decisions. True or false? If you could all vote now, please. Okay. Leo.
This was a nasty question. It's a bit of a trick question because I've put in the enduring power of attorney, which are actually the old ones. It's lasting powers of attorney, which came into place with the Mental Capacity Act. And the reason I put this in is it's really important that you check that a power of attorney is appropriate if you are presented with one. It's quite common for people, well, not so common now because the enduring powers of attorney have been out of action for a bit of time, but there might still be some which are valid for financial decisions. Also, with the lasting power of attorney, there are two types that you can have, one for health and welfare decisions and one for financial decisions. Quite a lot of people will have one for financial decisions and they think it's valid for the health and welfare. It's not. So you need to check that it is an appropriate power of attorney if you are presented with one. And basically, if ever you are presented with one, get in touch with us. We can advise you about that. It's the sort of thing that we deal with on a regular basis. It's not the sort of thing that you come across regularly in most dental settings. So if in doubt, just ask us. So yeah, the lasting power of attorney, as I say, can be for financial decisions or a separate one for health and welfare decisions. Also, they have to be appropriately registered with the Court of Protection. So basically, if in doubt, get in touch is always the thing to do. You've got time, it doesn't matter. People might get a bit shirty with you if you say something like that, but who cares, quite frankly? You're doing the right thing. Always seek advice. Advanced decisions, that's sometimes called living wills. Patients can make an advanced decision only to refuse a certain type of treatment if they lack capacity. They can't make an advanced decision which demands that they have treatment. So I could say, I refuse to have an acrylic denture if I lack capacity at any time in the future. What I couldn't do is say, I want to have implants if I lose my teeth when I lack capacity. So that's the difference between them. It can be written or verbal. Obviously, if it's verbal, it's much, much harder to follow through with it. And it must state precisely what treatment is being refused. It's not good enough to say, I refuse to have all dental care. That's far too broad. It's got to be really specific. So it's not just that general statement about desire to be treated or not. Again, they're pretty rare in dentistry. They're more common on the medical side of things. So yeah, and then if that advanced decision involves a refusal for life-sustaining treatment, it's that the requirements are far more stringent, but that's basically beyond the remit of dental professionals. We're not providing life-sustaining treatment for any of our patients. We're providing life-enhancing treatment, but we don't make that decision, or they can't say, I'm going to refuse to have a specific thing that's going to prolong my life. Dentistry doesn't fall into that category, thankfully. And I'm very pleased about that every day of my working life. Written statements, that's basically, it's not legally binding. It's just something that the patient puts down that you need to take into consideration. So if they do put a written statement saying, I don't want this in general, or I would like that, you need to just factor it in. And that is part of the decision making that you would make on helping to decide on the best interests of that patient. but it's not legally binding. So it's just something to be aware of and to consider. When it comes to urgent treatment, basically you do the urgent treatment. You don't find out about the advanced decisions. So if there is a medical emergency, you deal with it. Not least, even if a patient had told you that they don't want that, you don't know if they've changed their mind at any point and they've revoked it. So don't go around hunting for the advanced decision. Get the AED out, get on with the basic life support, deal with the medical emergency. You would not be justifiably criticised if you do that. And again, this is a really important point. If the patient lacks capacity and you do what's in their best interests, it is as if the patient consented. So you can be assured that you cannot be litigated against because of a lack of consent. But the treatment must still be of a good standard, of an appropriate standard. You could still face a claim if the treatment fell below the standard expected, but not because you failed to have the consent of the patient. So basically, to summarize, if you have decided that that patient lacks capacity to consent, you can provide treatment if it's in the patient's best interests. The two exceptions are if there's an advanced decision that you know about and if the patient is involved in research. But again, the chances of that happening as far as dentistry is concerned are pretty low. So,
okay, so what does this all mean when you're working? So it's you who needs to justify why you have decided the person cannot make the decision. So remember, it is the individual decision in question that you need to think about. Some decisions may be straightforward, others more complex. Capacity may vary according to the complexity of the decision. A patient's capacity may fluctuate with time, and a patient may lack capacity at one point, but regain it again later in the future. So it's just sort of bearing in mind all of these points when you're working in clinics.
So how do you decide? As we said, there's no definition of best interests. We've covered all of that already. So, sorry, the checklist. Section 4 of the Mental Capacity Act provides a checklist which you need to consider when deciding what's in the best interest. It's a starting point. So just take the following steps. Will the patient have capacity at some point in the future to make the decision? If yes, when? So as far as possible, permit and encourage the patient to participate. So get the patient involved as much as you possibly can, and try to improve their ability to participate as much as you possibly can. Then where a decision involves life-sustaining treatment, you must not be motivated by a desire to bring about the death of the patient. Again, I don't think that ever applies in dentistry because of the life-sustaining treatment. But for doctors, obviously that's a good reason why they mustn't treat their family, because there might be a desire to bring about the death of a patient. So yeah, you can't, that can't be the overriding thing. And then consider as far as possible patients' past and present wishes and feelings. So take into consideration all the other things that we've already discussed. And then consulting. Who do you consult with? If there's somebody named, so a lasting power of attorney, even if it's for financial decisions, they're clearly somebody who's involved in the care of that patient. So think about them. anyone else who's engaged with the patient. So if they come with carers, if they come with a spouse, a partner, they would be somebody to consult with, anyone interested in the welfare of the patient. Often there might be children involved. So just think who there is. And again, I've never seen a situation in with one of our members where there's been a deputy appointed by the court of protection, but in theory that could happen, but really that's rare. So don't make your decision on how they look, their age, their condition, or anything that you make assumptions about them. And then keep good records. So it's how did you reach your decision? What were the reasons for reaching the decision? Who was consulted to help work out the best interests? And then what factors were taken into account? And so keep that in the records. It's basically show you're working out, which we don't often do with our records. We do this is what was discussed, this is what I did. With this, it's showing how you reached your decision. And that's an important thing to record in the records. And consider that the patient might regain capacity in the future. That's always something to be thinking about. Is this temporary? Is it permanent? There are always easy decisions. There are clearly patients who have the capacity to consent. There are some patients where their condition is such that they clearly they don't have capacity and they never will. It's the ones in between which are always the tricky ones, and probably are the majority where you are having to make these sorts of decisions. So is it possible to delay until they regain capacity, and then keep a note of that in the records? Disputes about best interests. So think about getting a second opinion. There might need to be a case conference. I've never known a dentist have to call a case conference. I've known dentists having to be involved in a case conference. Think about mediation, involving an advocate, if there is one that you can call on. And ultimately, some things have to go to the Court of Protection. Again, I've never known one of our members going to the Court of Protection about dental decisions, but it could happen. So again, if there's anything like that happening, get in touch with us, get us involved, let us help you navigate the situation. Court of Protection is the specialist court. It was established under the Mental Capacity Act. It replaced the old one, which was only about financial affairs. The current one can deal with health and welfare decisions as well. So like the lasting power of attorney, the Court of Protection has those two arms to it now. It's got the power to decide. So ultimately the court can be the one that says, yes, the person has capacity or doesn't. It can make declarations. So it can say, this is what's going to happen. The Court of Protection can appoint the deputies to make the decisions. It can decide if the power of attorney is valid. It can give directions to an attorney. So it can say to someone who is an attorney, you need to do this. And it can remove the power of attorney from the attorney if they fail to carry out their duties properly. So the Court of Protection has a lot of responsibility. And then again, the use of restraint. You must be able to give good reasons why it was necessary. You must show that being restrained, they're less likely to suffer harm. It's got to be proportionate. And then the least intrusive type, minimum amount of restraint to achieve the object. So, as I said, in dentistry, it's rare, but it's that do they need a general anaesthetic, or can I do this under sedation? Would be the sort of thing that you'd be thinking about if you needed to sedate a patient. Sedation is less restrictive than general anaesthetic. So it's those sorts of decisions that you need to be thinking about.
Okay, and then just a final slide on children. So as you are all aware, the legal age of consent is 16. As a general rule, under 16s can't consent, and for over 16s, you should assume they have capacity to consent unless you know otherwise. Now, there are exceptions to the under 16 rule, such as Gillick competence, which is when you have a child under 16 with the appropriate maturity and they're able to understand and retain, weigh up, and communicate their decision, and you agree that it's in the patient's best interests, we can use Gillick competence. But ensure all of your steps have been documented and your reasonings for coming to this decision. For complex or irreversible treatments, it would still be advisable to seek parental involvement if possible. And also ensure that you are following guidelines from a reasonable body of opinion and that you keep up to date with any developments and CPD to prevent criticism. I'm just going to jump over to a couple of the questions because they're sort of related to this slide. So we've got a question: can older adult siblings give consent for younger under 16 siblings? And then attached to that is also, can grandparents give consent for grandchildren?
The answer to both is yes. In that the older sibling, they must be an adult, so they've got to be over 18. I know the age of consent is 16, but you become an adult at 18. So if the older sibling is over 18 or over, sorry, I should say 18 or over, they can provide consent because a parent can delegate the authority for giving consent to another appropriate adult. So a parent can delegate that to a grandparent, they can delegate it to a carer, they can delegate it to another sibling of the under 16-year-old. It's absolutely fine. I would always try and involve the parents in the decision making if you possibly can. They don't have to be present. That's another thing that we're often asked is, does the person have to be present with them? No, it can be done verbally. It can be done over the phone. Don't worry. But it's ideal to try and involve the parent if possible, because although they might have delegated it and you do have consent, what you don't want is that complaint saying, if I'd known it was going to be that decision, I would never have delegated the authority to them, which is just a horrible situation to be faced with. So try and involve the parents if you can, but actually you do have the consent if you if it's being delegated by a parent to an appropriate adult. Let's just see in the last few minutes if we can answer some of the questions. Do you have to record each time a patient lifts their hand? Very good one. No, you don't. No, that's, patients regularly lift their hand during treatment. You stop, they want to rinse, something like that. No, you don't have to record that. You don't have to record patient withdrew consent. No, it's you stop. If there's something where you have a bit of a concern, you might write patient didn't want to proceed with treatment, so that's something that you might do. Another one here that's caught my eye: patient wishes gold tooth on upper lateral incisor because his gran used to have one. Patient is very adamant. That's a really good one, because that's the sort of thing where you have to think, is this in the patient's best interests? And it's the sort of thing where different clinicians will come up with different answers. So it's one of those situations where there are classic differences of opinion between a clinician as to what is appropriate to do. It may well be appropriate to do it. It might be the most conservative treatment for the tooth. It might not. But one of the other factors that you have to put into the decision making is it being done because it's a fashion? About 10, 15 years ago, there was a fashion for a lot of gold on anterior teeth. That seems to have disappeared. It's now gone to a lot of white on anterior teeth. So you need to be thinking, is this a permanent decision? Is this something that is in that patient's best interest? And different clinicians will come up with different answers. So that's again something to build into your discussions with the patient. Do that. I don't think it's appropriate. Somebody else might, but I personally don't for these reasons. And then another one, which has really caught my eye. Sometimes patients do not like to hear or know the cons of a treatment and feel too nervous about having the treatment. Where do we stand in these cases? On one hand, we need to inform them of side effects of a treatment, for example, perio treatment. On the other, they say they feel too scary and doom gloom. Yeah, absolutely. And that's where your communication style needs to suit the patient. You need to make that decision about how you communicate the information in an appropriate way for that patient. So you need, it's again easier said than done. Yeah, I was too scared to do it because of all of that doom mongering that went on. We sometimes see that in complaints, but we see that more rarely than we see the I didn't know, I didn't understand. So ultimately, make sure that the patient understands and you communicate it in as sensitive a way as you can. Thank you.
Brilliant. Thank you, everyone.